Innovators Roundtable webinar on what's happening at the Mayo Clinic platform with Dr. John Halamka. Before I turn it over to Larry, who's our host for today's discussion, I would like to go over just a few of the housekeeping items that you see on the shared screen, which I will leave up for the duration of our conversation, Larry, for those who trickle in.
Yeah.
Okay, so upon entering this meeting, if you're not speaking, we've gone ahead and muted you for the time being. But if you have a question for our presenters at any time during the discussion, please raise your hand using the hand icon located in the toolbar on the top right-hand side of your screen. To view more attendees, switch your view from gallery to large gallery by clicking the three-dot icon and scrolling down to this option. You'll be able to use this feature once there are a number of attendees which we have already met. So you should be able to have access to that. And if not, you can email videoconferencing@foley.com with your difficulties. You may also need to refresh your browser or leave the meeting and rejoin, which we will of course be monitoring and we'll put you back in. If you'd like to keep Larry and John at the top of your screen, I suggest that you pin them by clicking on the three dots next to their name once their video appears on your screen. And with that, I'm going to turn it over to you, Larry.
Thanks very much. And as we were chatting before we started, this is our first time using Microsoft Teams as we take a, historically for the last 15 years, 2-day invitation-only CEO roundtable and spread it over a period of weeks through this video system. And so far it's working okay. We have about the same numbers attending as we have had live, but there's always a learning process and we're eager to get everybody's feedback about it. So without any further ado, let me introduce Dr. John Halamka, who many of you know and have worked with in the past, and his new role at the Mayo Clinic and the Mayo Clinic platform in particular as president is the topic of our day. We are both here in Massachusetts. Probably, John, you may be the Tom Brady of the health IT industry. Although I would say that the Mayo Clinic is a far better team than the Bucks. But we're still happy to have you living around the corner from us. Well, we have a few minutes together to talk about really some of the fascinating developments that are going on at the platform. As I understand it, the pledge is that by 2030, a quarter of the revenue will be flowing through the platform, which is a darn ambitious goal. If I'm not, and tell me if I'm quoting that wrong. But would love to hear about what is the Mayo Clinic platform and what's on the agenda.
Well, certainly. Thanks so much for having me. And here's the story about the platform. It was August of 2019, and Gianrico Ferrugia, the CEO of Mayo, posted the following job description. Wanted MD engineer with 30 years of digital transformation experience, extensive international travel, writing, and speaking to move Mayo Clinic to a digital-first organization, taking specialty knowledge and sharing it with the world through a variety of platform technologies. So if you were to read that job description, you probably recognize that the phenotype is not so broad, you know? And so I thought, oh, I don't know, but why don't I chat with these folks? And here's what I discovered. Mayo has created a 2030 bold forward plan of Cure, Connect, Transform that says, we know we need to be more virtual. We know we need to take telemetry from wearables and devices in your home and turn that into action and knowledge. And we know we need to think of just new care models that don't exist today. And so with that, Mayo Clinic chartered this platform, and I took the position in January of 2020. And I was handed 3 initial businesses to begin. And the first business is, how do you take 154 years of Mayo Clinic data? And before you say, what do you mean 154 years? How could that be? Remember, Mayo Clinic invented the medical record. Of course, back in the day before TCP/IP, it was pneumatic tubes, chutes, and various kinds of manual methods of tracking patients as they move around a building and ensuring a record followed them. But we have pictures and recordings and telemetry, 5 different EHRs by history, all this digital data, as well as things like 30 million pathology slides waiting to be digitized. It's a very large corpus of data. how do you take the data of the past and ensure in an ethical, privacy protecting way that it can be used for new cures, for new treatments, for treating the patients of the future? So the first challenge was working in collaboration with Google, who is a strategic partner of Mayo, to de-identify our historical data, put it encrypted at rest into a secure container, and then invite collaborators into subtenancy containers where they can run algorithms or they can run analytics or visualizations on that DID data. That went live in April, and it's 10 million patients, including structured and unstructured data, fully de-identified. And we continue to add to that. Omics is coming soon and various kinds of telemetry coming soon. But with that, what it means is that we have an AI factory, the ability to give to all of the Mayo faculty tools and the data necessary to generate new algorithms, to take their specialty knowledge and incorporate it into a scalable IT infrastructure. And so that has gone very well. We partnered with a company called Inference in Kendall Square in Boston, and they have provided a series of tools that help some of the pharma industry, Merck and Janssen, in drug discovery and identifying post-market surveillance, potential new drug targets, and maybe even subsetting where drugs are going to be most efficacious in patient populations. And we've signed a couple of other recent agreements that bring third-party companies into the DID environment for algorithm development. You'll hear more about that soon. The second business was the idea of delivering high acuity care at a distance. Of course, we see in this virtual COVID world lots of virtual visits, but those are mostly outpatient. So here's the question. Can you take an immunocompromised old that has serious and complex disease, hospital quality care with the same outcomes and safety in a home setting? So we partnered with Medically Home, and we'll talk more about that, I'm sure, and delivered in the Florida and Wisconsin marketplace home hospital services with skilled nursing, supply chain, specialty consultation, all in your living room. And that has gone well over the course of its couple of months of pilot. And there's more to do with expanding scope of services and geography. And the third business, and one that I'm spending a lot of time on, is, do you have an Apple Watch? Maybe you're monitoring your pulse, or maybe you're monitoring your ECG. Well, what do you do with it?
Right.
And what if you had a cloud-hosted service provided by Mayo Clinic that could take the telemetry from the wearable and say, 5 hours from now, you're going to develop an arrhythmia, or we are seeing a reduction in your ejection fraction. You may actually have something going on with your heart muscle, or potentially, and I raise this as potentially, diagnose COVID from the variation in your lead 1 ECG, the project we're looking at now. So the business is taking remote telemetry, and that can be, again, wearable, something in your home. It could be medical record data or image data, marrying it up with the algorithms we created as I started my discussion of platform, and then delivering a result, something of value to providers or to patients. A whole lot of what we do has to focus on privacy protection. So in these three businesses I've described, privacy is foundational. And one of the things that's a bit unique of what we've done is we've developed a next generation set of algorithms to DID the data. And we brought in third parties outside of Mayo to certify that it's DID'd. And as I said, we encrypt everything in motion and at rest, so that as we talk to the press, we say, we hold the data. We run these transactions in our platform, and everything is done with extraordinary scrutiny and external certification. And that's really important if you're going to start up a platform business. So there you go. There's sort of a brief introduction into these three areas of big data, acute care at a distance, and telemetry and AI algorithms turned into action. And of course, many other businesses and opportunities will be coming because 2030, because of COVID, has become more like 2021.
Right. Well, let me remind everyone that this is a discussion panel, and despite the fact that some of us are separated by hundreds of miles, feel free to raise your hand through the functionality of the Teams meeting, or send a chat question if you're shy and you don't want to ask your question live. But we'll welcome conversation and comments along the way. I want to kick it off though by here. I heard you say cure, connect, and transition.
Transform, yeah.
Transform, and that made me think about the historic three shields that Mayo has of research, education, and treatment. I might have that wrong, and I'm wondering, is cure, connect, and transform another version of three shields for the 21st or 22nd century, or is that just a coincidence?
Oh, don't worry, just a coincidence. So Mayo, of course, has these three shields of the practice: delivering clinical care excellence, research, and education. And the idea of cure, connect, transform really does apply to all three shields. So the idea, of course, cures, well, we're going to do research to make sure that we have cutting edge cures, that we develop that next generation of protocols and treatments. We are going to connect more patients digitally than ever before, both internal to Mayo Clinic and through external partnerships and collaborations. And by transforming the healthcare system, what we mean is fundamentally changing the care model, especially with doing virtual care. So the Cure, Connect, Transform really does apply to all three shields, and the shields haven't changed.
What's the we did have one specific question about the acute care home model. Before we get there, I want to stay sort of at the higher level while thinking about the Mayo Clinic platform and the physicians, many of whom have been with the Mayo Clinic for their whole careers. What's been the physician reaction to the platform? Is it an endorsement, resistance? Where do they come out on this?
So it's been extraordinary support. And let me give you a couple of reasons why. Can you, I don't know, in your experience running these innovations, describe to me how much doctors love their EHR?
Yeah, they live for it.
Indeed. And so you have 11 minutes to see the patient. You have 143 structured data elements to enter. And you have to deliver perfect quality of care and be empathetic and make eye contact while doing all this with your computer. Pretty hard, huh? And so when we describe the idea of, well, what if we were able to take the EHR data you have so meticulously entered since 2009 and actually return value to you? Tell you, for the patient you're about to see, what are the 5 most likely diagnoses? Or for the breast cancer you just diagnosed, what is the best practice based on 10,000 patients like the one in front of you? Or being able to, and this is actually a use case that we're working on, if you're a radiation oncologist, you will still, of course, make the final decisions, but an AI algorithm will reduce the time to a radiation therapy plan by 6 hours. You used to have to meticulously spend time reviewing these things, and now you're just doing the cognitive work and the algorithm is doing the rote work. So every physician says, oh my God, you're going to reduce my clinical burden. And that means that I'm going to have more time to practice at the top of my license. And it means I'll have a better quality of practice life. In fact, it even means that I'll probably make fewer mistakes. Quality will go up. Malpractice assertions will go down. This is great.
Terrific. So again, welcome questions from any of us around the round table. We did get one on the advanced care at home model, and I would like to hear, for those people who aren't familiar with what the advanced care at home model is doing, maybe you can give us a little more background on just how acute and what kind of services are provided in the home. The question we received, though, was asking about the reimbursement model for it. And we're obviously aware that there's a number of home hospital models, a term you did not use in your description. There are a number of home hospital models coast to coast, including some others that the vendor you mentioned was involved with. But tell us a little about the Mayo version of it.
Well, sure. And so the idea is that, and especially at a time of COVID, you're probably going to want to decant your bricks and mortar facility of not COVID patients. Because do you really want elderly patients with multiple comorbidities going to a physical location? You probably don't. And so Advanced Care at Home says, first, we're going to triage the patients to make sure they're appropriate for this model. And that means that they have a place that's safe and accessible. Bring into the home the equipment that is necessary to treat serious and complex disease. And we'll bring in home nursing, community paramedic services, or others as needed. And that we can replicate the same care plan for CHF, COPD, pneumonia, renal failure, hyponatremia that you would have had in a bricks and mortar facility in your home, but you sleep in your own bed and you have access to your pets and your family and the familiar surroundings. So I'm just looking at our dashboard right now and looking at what we have in Florida and Wisconsin. And what we're dealing with is, a vast number of patients that certainly could not be treated as an outpatient. We've begun to not only provide the acute care services that you think of traditionally as a ward bed, but also rehabilitation services in the home. And our Florida location has even piloted emergency department services at the home. So imagine this, you have chest pain. And we set up an evaluation, an emergency visit in your home, determine what the nature of that chest pain represents, admit you to your home, care for you in your home, discharge you to rehab in your home, and then over, let's say, a course of 16 days, start to finish, you're back to a level of wellness all in your home. And that's the concept. Now, the question about reimbursement is there's really two aspects to this. There's private pay, and then what happens with Medicare, Medicare Advantage, Medicaid. We know in a time of COVID, we've seen some important regulatory change and waivers. And so a couple of things that are important. We no longer depend on state level licensure for care delivery from specialists. So what that means is that a doctor who may be the world's expert in your disease, who's sitting in Minnesota, could deliver that expertise to North Dakota without having to be cross-licensed across multiple states. So it democratizes access to specialty knowledge and care. So that's great. As well, these reimbursement waivers include things like DRGs that allow us to develop a hospital without walls. And so what we're seeing is that we can deliver this care that would have been a bricks and mortar level of reimbursement in a non-traditional setting for pretty much the same level of reimbursement. And of course, you're going to say, well, wait a minute, won't this be rolled back? Won't these waivers and regulatory changes go back to what was a traditionally not so well reimbursed model? Everything I hear from everyone in government and CMS and HHS is there is no intent to roll back these regulatory changes. And certainly the professional societies like the American Telemedicine Association, hashtag of the day is don't roll back.
Right.
So I think the answer is we can achieve pretty close to parity right now. But obviously we're looking forward to working with private insurance, coming up with bundles, figuring out novel ways that private insurance can fund what is costs of care substantially lower than bricks and mortar care and ensure there's a long-term revenue model, even if there is some regulatory change ahead.
We got a question from Ori Jacobs. Did you want to unmute yourself and go ahead?
Sure, John, this is a follow-up to what you were just talking about. I think I know the intent of what you're implementing is to improve care and reduce costs, which is going to ultimately mean less admissions, less emergency room visits, etc. most health systems have majority of their revenue coming fee for service. And it's a delicate balancing act in how quickly you try to implement these programs and yet stay financially strong. How does Mayo look at that?
Sure. So there's a couple of answers to your question. And let me take Northwest Wisconsin as an example, because we've rolled out this Wisconsin area as a service for the advanced care at home. Capital isn't so readily available these days. What if I told you that without building a single additional hospital room, you could double your clinical volume with your existing staff by delivering care in the home and using a platform approach to remote patient monitoring, care planning, and being able to ensure orders and results and all the usual stuff happen? What we've heard from stakeholders is, they would really, even though what you say is, oh, might this eliminate some fee for service business, but they could so significantly increase the number of patients they treat by not having to worry about physical proximity or bricks and mortar, that they believe it actually will grow their business to do business this way. So sure, fee for service, it's growth in volume because you don't need those hospital beds. And obviously, if you have a risk-based arrangement, delivering care at lower cost is certainly to your advantage.
Mhm.
And we'll be able to expand into geographies that we have not been traditionally able to expand to before. So in many ways, whether it's national or international as a service, it will ultimately increase revenues.
Thanks.
And I was asked a question I see about what do you measure besides revenue? Well, remember at Mayo, the patient always comes first. And when I look at the KPIs, and there are many of them, but one of the most important KPIs is a net promoter score. How did the patient and the family rate this experience? And here's a quick story for you. So we had an 87-year-old patient who was acutely ill. And his spouse, although no acutely ill, was undergoing chemotherapy treatment. And that spouse felt that the home situation was overwhelming. And so by doing a hospital at home, so to speak, as you say, advanced care in the home, we're able to treat the whole family, the whole household. And what we decided was when we brought the appropriate meals to the patient, we would also bring appropriate meals for the spouse. We fed the whole family because we really did an assessment of social determinants of health and what was needed to return the family to wellness. And that has resulted in these net promoter scores that are really off the charts.
And folks should feel free to raise your hand or put a question out there. One of the things I wanted to follow up on was your thoughts about cross-state licensing. Obviously, one of the most annoying barriers to expansion of a telemedicine platform is getting your docs licensed in all these places where their patients may reside. And you had somewhat of a rosy prognosis for that, it seemed like. Did I misread you on that?
No, I'm actually quite rosy about this because of the waivers of state level licensing that have already been rolled out. Well, let me give you just a personal example. And so I see Lyle Berkowitz has joined us, and he knows me very well. I do 900 telemedicine consults myself every year. And how does that work? It's a little bizarre, but I am the nation's expert in poisonous mushrooms and plants. Every time a child or a teenager or an adult has an ingestion, the poison control centers of this country contact me. And I get on my phone an image of what was ingested, a case history, and I come up with a treatment plan. It used to be that I needed a licensed physician in every state, and that physician would consult with me, and using that physician's license in that state would decide whether my advice was good or bad and take action. And since these waivers and regulatory changes, that's no longer been needed. So far, so good. And, sure, there are problems to solve. I was with colleagues working on an article last evening. A lot of the oversight of physician malpractice is done by state medical boards. So here's a problem. We could ask Dr. Berkowitz to solve this one. Imagine you did horrific things as a doctor in Nevada, and now you're developing a telemedicine practice in Georgia. Okay, who's going to regulate that? Who's going to sanction you? Who is going to decide that you shouldn't be doing telemedicine in a different state if the state medical boards are the adjudicating authority? So yeah, there are problems to solve, but the regulatory framework is certainly improved.
One of the questions that came into me through email was looking back at the advanced care at home model and sort of what's your thoughts on expansion of that into other jurisdictions or states? Were you going to watch it for a while in Florida, Wisconsin, or are the early returns good enough for you to start thinking about the future?
Yeah, there's a couple of answers to that one as well. So what we've done with Medically Home is created a platform that is hosted in Google. It's all, of course, encrypted, and Google doesn't have access to it, but it's using the most state-of-the-art technologies. It's Docker, it's Kubernetes, it's Bigtable, it's all that stuff for folks who work in cloud-hosted environments. And it's being used by others than Mayo, right? So one aspect of expansion is I run a platform business, and therefore it's actually okay to empower other healthcare systems to use that platform that we've created with Medically Home with their own command centers and their own patients, because there will be ultimately revenue coming back to Mayo that's platform based. Think of it as Care B&B, so to speak.
Right.
So that's great. You can scale quite widely if we are using other healthcare systems, resources, and expertise on your platform to deliver care in different geographies. But that being said, you are correct. There's two ways to expand. One is that's the scope of disease we're going to treat. And we just submitted last evening a proposal for expanding advanced care in the home to cancer care. And looking at how you could do end-to-end treatment of serious and complex cancers in the home, including home-based chemotherapy. So that's fine. So you're going to treat more diseases, and you're going to have much, maybe hundreds of chemotherapy patients a month that you're helping with the most advanced chemotherapy protocols at a distance. And then, as you say, expanding geographies as is appropriate. There are some issues. Are there the right number of staff trained in home care for the serious and complex? Might Mayo have to help with training and certification of the cohort of individuals that is going to now deliver care at a home in different geographies? We might. So we're looking at the expansion of geography in terms of supply chain, access to evacuation. What if you need to go from the home to a hospital urgently? And the staffing that is needed to ensure you get the services you need in your home. And maybe the last thing I'll mention on this is, it's going to sound utterly prosaic to this audience, bandwidth. So you might think, well, what do you mean? Internet connections to the home, that's not so hard. In the United States, there are a whole lot of areas that don't have broadband and have lousy 4G connections. And that is a gating factor to expansion of your advanced care at home model.
Yeah, we have heard about that. And certainly during the COVID expansion, folks were using, regular landline telephones for their telemedicine consultations. Not ideal for sure.
Well, exactly. But hey, Elon Musk is now offering Starlink for $99 a month. Maybe that'll help.
Probably. Got a couple of comments or questions through the chat feature. Dr. Berkowitz did respond that the good news is that the states do check with each other on licensure, but it's not perfect. Ideal would be a federal database and licensure. Couldn't agree more with that. You probably have a similar perspective.
So, of course, Lyle is always right. But in this paper that I was preparing last night, what you'll discover is we actually can do better, as he says. That there are a number of states, unfortunately, that haven't checked other state databases. So some are good, some are bad. Your mileage will vary.
Yeah. Well, it made me think of the RMVs that don't check trucker licenses across state lines, leaving them to pile up. So
Right.
leaving it all to each state to read the envelopes is not easy.
Right.
Marcy asks a good question. How will you develop the tools for the physicians that you mentioned such that they will really use them and find them valuable in a short appointment? And she asks about IBM Watson, which didn't have very good luck with that. What are you guys going to do differently, she says.
So what a brilliant question this is. So I'm an emergency physician. And when I hear pitches from startup companies and they say something like this, well, you're sitting in Epic or Cerner and you're doing your thing, but we have got this great new product. And all you have to do is pick up your phone, log into an app, go do some decision support thing, and then go back to Epic or Cerner. You'll love it. No. Right? You need to be able to deliver that clinical decision support, that advice in the stream of workflow. And there are a couple of ways to do that. I mean, there's certainly Smart on Fire, a app that is integrated on top of existent Epic and Cerner workflows so that it really feels like it's part of your Epic and Cerner installation. Or Fire CDS hooks, which Epic and Cerner have built so that you're in Epic and Cerner, it calls a cloud-hosted decision support service and returns a result in line. And there are other approaches that I've seen used that aren't so wonderful, but they are what I call sidecar applications. That is, things that sit on your screen that might be right next to Epic or Cerner. Doesn't really require you to go to a separate login or separate app. And so every business that we have started, or every project that we do, we always ask the question, how are you going to deliver it to the patient, the provider, pharma, the payer, whoever it is, the end customer, in workflow? Because that's absolutely key. And example, just to give you something concrete, we have an algorithm that can take a look at your 12-lead ECG and tell you your ejection fraction. Now, of course, you'll say, wait a minute, don't you need an echo for that? Well, with an AUC of 0.95, we can actually tell you your ejection fraction from your 12 lead. So that means that on the 12 lead itself, that we actually show you, in addition to the interpretation, the ejection fraction, the risk of hypertrophic cardiomyopathy, the risk of future AFib, and pulmonary hypertension. So it's just right there, right in front of you as you are looking at the test result anyway. And that's the kind of thing you need to do if you're going to foster adoption.
So far, the conversation that we've had about the platform projects has focused on pretty high-end clinical activities and provider-facing, physician-facing technologies. But you also mentioned, as part of the mission here, is a sort of a consumer-focused approach using Apple Watches and other, owned technologies. Is that a future-looking piece of the platform? Working on it now? Where does that come out?
So let me answer this one in a couple of ways. So when I was hired in January, same exact time, Rita Khan was hired as the Chief Digital Officer of Mayo. And if my role is platform construction, external relationships, collaborations, the sort of laying the infrastructure foundations, her role is to change the patient experience at Mayo, to ensure that within the Mayo app that there are new features and functions, remote patient monitoring is enhanced, and even the physician experience is enhanced as we bring in these new tools. So I guess to your point, the business to consumer part of Mayo largely lives within Rita Khan's organization, the Center for Digital Health. But that being said, there are collaborations that we have done that are consumer facing from the platform perspective. So let's talk COVID for a second. So I'm looking, you are socially distanced in your library. Very nice degrees I see on your walls.
They're fake.
So, for example, when you look at the 5 phases of COVID, we started with isolation. We all retreated to our offices. And then we started to venture out. And then we started to need testing and contact tracing. And then we're going to presumably have a pre-vaccine return to work. We'll want to know about cures and their efficacy. We'll have post-vaccine. We'll need proof of vaccine for some events. And then there's the new normal. So one app that we've worked on in collaboration with a company called Safe Health System is the notion that we can ensure that you, while you're social distance, can get the testing that you need to get the proof of test result you might need to travel between states, to get the telemedicine advice in a more automatic fashion. So the idea is you pick up your phone, you say, oh, this morning I was feeling fatigued and I've lost my sense of smell. And then 5 seconds later, a physician appears and says, yes, I've read your signs and symptoms. You need a test. I'm ordering the test now. The test could be a lab-based test, or it could be we send you a swab, or it could be an in-home test as the EUAs for those became available, with the result then returned to your phone and certification of your result on your phone. So part of this direct-to-consumer idea, especially around COVID, is just figuring out for all the progression of disease, who is going to need what function and how do we provision it? And that's being done in collaboration with commercial companies.
So Dr. O'Kane from NCQA asks a very thoughtful question about virtual care. Virtual care offers the opportunity to redesign workflows. Will trying to fit into current workflow design limit possibilities?
What a brilliant question, but of course, how could I expect anything else from Peggy? So think about the hospitalist movement. What did we do? We took patients in hospitals and said they need specialists because this workflow it's really, if we want quality and safety, it really needs specialty training. So here's what I would argue. We need virtualists. And these are people who are trained to deliver care at a distance, recognizing the digital tools that have evolved to do that are more sophisticated than ever before, but the thinking, the nature of your workflow is going to be different in a virtual environment. So I think there's no question that, what I've always told people is automating an existent broken process just gets you a worse result faster. As opposed to rethinking the process. How do you make it virtual first and ensure that the people who are delivering the care are virtual focused? And this is going to sound a little bit odd to you, but we're so used to admitting patients to a virtual space in our Florida pilot. We've actually given our virtual hospital, a floor and room designation. We're going to admit the patient to the second floor room too. Well, that doesn't exist.
Right.
And we've integrated into Epic a set of workflows so that it doesn't feel any different to admit and treat a patient in a floor that doesn't exist than a floor that does, right? So part of it is, you change the workflow, you change the tooling, and you change the people. And then suddenly such a model becomes very natural.
We've only got about 5 minutes left, but we got a question that follows up on that pretty well, I thought. Are you doing any thinking about how to help triage care to the right venue as we expand the venues for care? App, text, video, phone, in-person, in-hospital, in-home. One of the concerns, for example, about telehealth is that it'll create additional appointments.
What a brilliant question as well. I love this group. I need to be very careful here because I am not endorsing any company or any service, nor am I declaring any conflict of interests.
Right.
there are a couple of very interesting companies in Israel. And when I look at a company like Diagnostic Robotics that has been affiliated with Sheba, or K Health that's done a variety of work with Ikilov and Rambam. These are startup companies that are using AI to triage patients requesting visits to figure out right place, right time, right care. So imagine that my medical record's public, so this is like not very interesting. I have primary hypertension and I have glaucoma because you can't pick your parents. If I develop an acute fever and I have literally no comorbidities, and the likelihood of that acute fever is a URI, or the flu or something. Well, you could say, oh, for your medical record, for your geography, for this time of year, here's what 1 million other people like you did and got success. Go here. And so what Diagnostic Robotics, K Health, and other startups like that do is they are that AI-based triage function, figuring out who gets telecare, who needs on-prem care, who can deal with outpatient, who needs inpatient. So for lack of a better term, you are totally right. We need automated care traffic control. And AI approaches to this seem to, certainly an early Israeli experience, seem to work pretty well.
Well, we are right about at 12:45 Eastern, and we want to let people go on time. I want to thank you, Dr. Halamka, for spending some time with us today. I hope you'll join us again, whether live or still virtual. The next of our sessions is in about a week. I'm sure Maggie will tell you more about it as we close, but I do want to thank you again, John, for joining us, and everyone who asked questions, in particular my colleagues at BDC and AMN, who are the co-hosts of this roundtable with us. I wish we could all be together for our dinner and cocktail hours and all that fun stuff, but and we soon will be again. So thank you. And Maggie, would you wrap us up and be sure to send us a teaser for our next session?
Yes, sir. So again, thank you everybody for joining today's program. And thank you as well, again, Dr. Halamka, for joining us. Our next webinar will be a week from today. So November the 4th, same time, place, different link, on emerging models of ambulatory care with Barry Arbuckle from Memorial Care Health Systems and Dave Anderson from BDC. An invite link to this webinar will be included in the follow-up email to all of you following this presentation, so keep an eye out on your emails.
And one of the questions that was asked is, are we recording these? We do record them, but only for the use of the roundtable members. So you'll be given a secure link to how to access it. And please don't share it outside of the group. The whole purpose of this is to facilitate conversations and idea sharing and not make people feel like they need to be worried about sound bites ever coming back to bite them. So that's it. Thank you all. Have a great week. Happy Halloween, and stay healthy, everyone.
And thanks so much. What a great group.
Thank you, everybody.
We're lucky to have you. Thank you.
See you.